Okay, so our next presenter, Dr. Ruth Crowther, is a clinical psychologist who works as a therapist lead at the Banyans Rehabilitation Facility and in her private practice, Quadrant Psychology. Prior to this, she worked primarily as an academic, most recently being a member of the MPRAC team led by Heidi Sturck. Ruth works with a range of clients and, where possible, utilises digital mental health tools and increasingly AI to help support them at different stages of their journey, regardless of their presentation. So today, Ruth is presenting on the integration of digital mental health resources into healthcare. So thank you, Ruth.
Thank you for the intro, and also for the opportunity to come and talk to you guys today and the people that we have online. When the invite to talk here initially came through, I was trying to work out how anything that I could talk about would fit in the context of the broader forum. And I think I landed on hopefully some key learnings that I can bring that will be valuable for the participants in this. But in listening to some of the speakers as well, it's really become apparent to me that one of the contexts within which I work, which is the private residential facility, which I'll explain a little bit more about, actually has a couple of parallels with a lot of the environments that you guys work in. So maybe some of the learnings around one of the projects that I'm trying to implement in there will be translatable or generalizable to some extent to the environments that you guys, the delegates here, work in. Make sure I get this the right way around. Hope I got this right. Okay, initially, so I'd like to acknowledge the traditional owners of the lands on which we meet and pay respect to their elders, past, present, and emerging, and to their traditions, customs, and knowledge. I'd also like to acknowledge anybody that's here that's dealing with their own mental health distress or are supporting somebody who may also be experiencing similar. So in terms of what I'm going to talk to you about today, these are the key things I want to talk about. So initially, how can digital resources support best practice? What are some of the perceived barriers and facilitators to implementation, which I think is going to be a key part? Changing digital behaviours in healthcare and specifically healthcare teams. I've put in brackets here therapists. That's probably slightly misleading in context. It's broader than that, but I guess given that I am one, that's where my mind kind of goes. And within that, we'll talk a little bit about digital champions, which is something that Heidi talked about just in the latter end of her presentation. Similarly, the digital toolkits, what strategies are available to develop confidence and competency in actually utilising some of these tools within the organisations within which we work? There's going to be a couple of bits I'm going to talk to as we work through the slide. Well, as we work through the slides that actually won't have slides that are relevant, because as I've been listening to the people talking, I'm thinking of things that I can add in. So if you need something else later that's in there, I can add that. So this is a slide that may look familiar. I borrowed it off Heidi's slide set and threw it into mine. These are the key areas in which the digital resources can support best practice. So Heidi's already given you a bit of an overview of what these are. I wanted to add an additional bits in the context within which I work, which is the rehabilitation facility. I have built a project that regularly and consistently uses digital resources to support people at discharge. For a lot of people that we work with, and I'll give you an idea of who they are, but for example, I work with a lot of veterans. They don't necessarily get aftercare, in which case we use resources to support them longer term when they leave the residence. Similarly, people who get aftercare with our counsellors within the organisation, we try and incorporate digital resources into there. So it's very much across those three areas that we'll use it. So we use it with the blended care for people who have aftercare, guided support for people that don't, and similarly with referrals. So I'll talk a little bit more about that and what that looks like. I'm going to apologise up front for the busyness of this. there's a huge amount on there. I also want to acknowledge this is the work of an honours student who I had the pleasure of working with and supporting when I was working within the MPRAC team, who was really interested in looking at the transition or the pivot to online tools during COVID, so early start of COVID. So what she did, she developed up a instrument that she then used to collect data from a lot of practitioners who'd had to suddenly pivot into the online space. Not necessarily telehealth, although that was also a key part of it. She also incorporated utilization of some of the tools that we knew were in existence, but had been underutilized previously, really for a range of reasons that this illustrates maybe why. Heidi's slide would have shown, or you would have noticed in there, that sort of increase during COVID, and then it's sort of gradually dropped off a little bit. I mean, it's still higher, as Heidi said, than where it was, but those numbers have started, so there's a downward trajectory in that. And I think this is where we've got this sort of key point of being able to support people to start to just bring that up where appropriate and necessary. All right, so I'll talk you through this. So this is the results of the survey, and she also did qualitative interviews with people about how are you adjusting to the online landscape technically? What are the barriers? What are the things that are enabling you to actually pivot? Because really, a lot of people had no choice. It was something that was driven. The key parts that came out of this is from her qualitative analysis. So capability was a key one, opportunity, motivation. And you'll see within that, she's done a thematic analysis of the things that sit under that. And I'm not going to go into too much detail as to the specifics of that. Suffice to say, some of the key ones are with the big sort of shouty stars that you've got on there. So in capability, some of the keywords or the key themes were around, we don't know how to do this stuff. And the organizations don't know how to do this stuff. How do we even suddenly pivot, particularly if we've come from a place of primarily face-to-face? We really don't have any policy or guidelines about this. And I think it's fair to say, a lot of us are acutely aware that there was a brief scrabbling of time where policies and guidelines suddenly had to be implemented to be able to adapt to the way service delivery had changed. So the knowledge component was really key. Relevancy of e-mental health resources and the awareness was an issue, but it was less of an issue in part because of the huge amount of work that both MPRAC and the Head to Health site has done around increasing awareness. So people know that or knew that stuff was there. They just couldn't quite figure out how to make it fit in. Motivation. Key ones in here. We're really stressed was the feedback. We're having to pivot on a dime. How do we even think about a new model of care, let alone understand what it looks like? There was also a fairly unfounded pessimism towards literacy levels for people. And upon sort of further exploration, it didn't really have any established basis. So that was something to explore further. And moving across to environmental context and resources. Now, this is probably the bit that's of more interest for you guys and also for me in the context within which I'm trying to implement a organization-wide approach to utilization of digital tools. Client access to technology, something to discuss further, the risks that are associated with that, and how do we create a framework that ensures that's done in a safe, secure environment. And practitioner access to technology. I've not put a star on that, but that's one that just sits underneath. So again, it's around implementation and appropriate infrastructure and facilities, tools that we have as employees. So this is just some of the key findings. As I said, I'm not going to spend too much time on this. Suffice to say that it's probably confirmed what a lot of you who were working in this space are already aware of around what those barriers and facilitators are. We know that there was a marked increase in the interest in digital mental health sites. Again, Heidi's data really nicely illustrates that. The interview data and the survey data showed that practitioners have really low levels of confidence in both clients and patients' receptiveness to digital mental health. And research since then, because this is a few years ago, has shown that actually that's not the case. So I'll give you a tiny bit of a context. I'm mindful, don't want to go too long. So in my substantive role of working in a rehabilitation centre, so essentially it's a place generally people will come for a 4-week block of time. Sometimes it's 2 weeks, sometimes it's 4 weeks, sometimes it's 6 weeks. Initially set up primarily for addiction. We have a lot of veterans, we have people, depression, anxiety, a lot of women with burnout come up here. The range of presentations is extremely broad. So the demography of people that will come to the rehab is veterans supported by DVA. We have a lot of NDIS residents who come and stay with us supported by their NDIS program. We have private paying people, and we have people who will come supported by their organisations. For example, depending on where they work, what their role is, sometimes their organisational insurance will support them on that. The strategy that I've come up with is around, okay, we have the 2 houses. One has 10 residents at a time, the other one has 4. It's pretty much like it's a locked down facility, but it's not. People arrive, they don't know where they are necessarily. They hand over their devices. So part of it is it's a digital detox. Number of reasons for that. Primarily, have a lot of people with addiction. And we are supporting people to withdraw from everything, including the dopamine they get from their detoxes, from their digital devices. That's a real challenge and doesn't always work. The other bit that I want to add here that's also important in this context is we've had, I think this year, 4 guests who've been to stay who are under house arrest. So we also have people, again, that come into the broader pool of residents that are there who we really don't want to have devices. So the project, what it looks like is, the plan is, which we've started in the smaller house, which has 4 people, a device goes in each room. So that's at this stage, it's an iPad. We've just bought the iPads. It's a lockdown iPad, and all of the onboarding, et cetera, will be done in there. People's schedules, their therapies, everything will go in there. So too would all the tools that we want to support people to use to be able to monitor them whilst they're in the house, or that they can obviously consent for us to monitor. So examples of how that might look is, let's say they work with a psychologist 4 days a week. They also get art therapy, music therapy. There's lots of things that are happening there. We implement a mood monitoring app that sits in the tablet, and then they just log that morning, usually lunchtime, in the evening, depending on how they're going, how they're feeling. So we started to build a picture. They also get medication sort of management within there. So we're also really interested in seeing how people adapt and their experience of that. What else is on there? Outcome measures. So we'll regularly do outcome measures to see how people are going. So things like the DAS-21 is in there, the PCL-5, some of the compassion scales are included. There's multiple kind of things that we're looking to put in. Initially, because obviously it's an organisation and there is a monumental concern around risk, it's not unheard of that people will use their devices to, well, A, distract from any of the work because, it's uncomfortable. The thing about sitting in rehab is you have to sit with a lot of stuff. People don't like that, which is fair. So trying to implement an organisational wide agreement that getting the devices put away has been challenging, because that also impacts people's desirability to come into somewhere. But secondly, the risk aversion. It's like, how is this even going to work? And, you know, the narrative in the round tables that we've done are, you know, people will have substances delivered, which has happened. You know, if we put an app on there that supports them to move towards sobriety, and we want to get them, you know, linked in with these organizations before they leave us, there's peer support groups on there. What's going to happen in there? You know, so trying to really come up with the solutions to the problems that we know are there, but that don't seem to have obvious solutions to a lot of the senior levels that are really worried about this. So that brings me back around to the digital champions. We need people who support the narrative, normalize the narrative, that digital tools are there. You know, Heidi's shown on her slides the expansion in this area. It's not going away. So how do we ensure that we really maximize it to its full potential in order to really improve the care that we provide the people that we work with? I've put in here as well around AI, because I know that's a theme that keeps coming up. So whilst we don't really, that's probably, it's a conversation that happens in the rehabilitation facility. It's not something we use there. It's something I use a lot in my private practice, and I'll talk a little bit more about what that looks like in there. Again, key things: create the infrastructure, provide the solutions. The key barrier is the access to devices. How do we overcome that? Okay, we allocate them to a room. We put all various different safety measures in and security measures. Challenge with that is that there's a lot of creativity. Sometimes we have a range of people from a range of backgrounds who have a whole wealth of knowledge about how to get into systems. So our devices are only as good as the staff, our IT staff who secures them. So ensuring that's solid. I think part of really normalizing the narrative around using the digital tools and AI is, and I think Heidi made this point, I'd be curious how many people here have some tools to manage their own health and well-being on their phones or on their laptops. Probably most of you, I shan't ask, but there'll be a lot. Check in with people. Are you using them? What do you think? So drawing on staff knowledge, what do you like? Do you recommend it? And also, this is something I know, a dialogue that's been happening for a long time. If a lot of the competencies around implementation of digital tools is embedded in the training programs, then we're not coming from the top down, we're bottom up, and it's going to make it much more of a consistent, smooth transition. Buy-ins, what are the gains? You know, I use them all the time, and in terms of the efficiency that it provides for me in my practice, it's significant, particularly checking in prior to sessions on getting outcome measures completed, and then checking in on, for example, if people have, I work with some people with eating disorders, checking in on the records on that can all be done beforehand, and then that's the conversation when you get in. So when we've got a 50-minute window on the Better Access, the mental health treatment plan, it's short. So it really, really supports maximizing efficiency in those spaces. Plus, as I think was mentioned before, somebody will present with addiction, and we, you know, as we're working together, we identify the trauma underneath that. So pulling in the addiction resources while we support in session with what it is that's underlying that, and doing some of the somatic work, is again all about enhancing efficiencies. Gamification. This is, I don't have any data for this, but my anecdotal observations are that people love the gamification. So I work with a lot of people when they leave the rehab down the track. We follow them up for 2 years. They will not lose their streaks. They're like, I've got these streaks, I'm on 248, and that becomes one of the key factors that helps them with not wanting to relapse. As I say, anecdotal. I will find some data on that. Easy wins for common presentations. There's one recently, I put it on here. There's lots. So anything that I name here is not necessarily a full-on endorsement, as this is the best of all of them. Contain Your Brain is one that I think has come out fairly recently. I think it's Australian, and it it's a bit like worry time. So it's a CBT strategy for managing ongoing worry and rumination. It's an easy win. Not to say that it, they still have to do the work with it. Clear exit strategy. It's a clean part of discharge process. People like tools. One of the common things that a lot of people say to me when they come in and like, okay, what are our goals? What are we doing? We've got a month together, 16 sessions. What do you want to take away? And they're like, I really want a toolkit. I want strategies. I want tools. It's a really nice way to provide that without focusing, obviously, entirely on that. I've added this again. How am I for time? The idea of digital toolkits, I think, is a really nice one. Again, having worked in this space for a while and through Chloe's honours project and with other conversations with health practitioners, it almost feels a bit ad hoc. It's like, oh, there's this app. This is great. Let's give this a try, without having a clear infrastructure or coherent plan around how we can bring this into our clinical practice. So I have a version of my own, one of these. Organizations arguably have the same. So I've started to build this with the rehab, but this one's very much based on the one that I use in my practice. So initially, expectation setting. So when somebody will come through as a new referral, there's like standardized information sheets that go out with the consent forms. And then they're reviewed when people come in. It's like, that's what this is, just so that the narrative is there from the start. And often people are like, oh, yeah, okay, I kind of know what that's about. I've got this app on my phone. I've got Insight Timer. I do mindfulness all the time. For those that don't, then we have a bit of a discussion around what that is. And not often, but sometimes they'll be like, yeah, no, I just want to come here and talk. My life's chaos. I'm really busy. Not interested. It's not a problem. The other form that goes in there, and this goes back to the AI that I mentioned before, is I now have a consent form that goes out with my standard consent forms that's about, well, it explains what AI is. So I don't know if some of you are aware, in this space, there's now a big explosion of using AI for note-taking and structured GP letters, that kind of thing. So one of the ones that's a lot of people are talking about is Heidi Health. So you can use templates to then go, okay, some people will record their sessions, whole debate around that, and people sit on different sides of it. But the consent form is like, it explains how the AI can be used, one way of which is for transcribing of sessions. Explain what that looks like, it gets deleted, gets reviewed. Probably have a colleague who sees a lot more private people than I do. She said to me recently, she's had 3 out of 100 who have declined and who have been really uncomfortable with that, which is actually way lower than I thought it would be. I've been using it. I haven't had any declines yet, but I'm still in single figures. So watch this space. Introduction to resources. So this way up is one I use really commonly because it, as a registered clinician, you can prescribe it. Printed off information letter. They have a letter that says, this is what this is all about, and gives them a bit of an idea. I always have a spare iPad that's knocking around, and it has everything loaded on it. So it's like, I think Contain Your Brain might be really good for you. Do you want to have a look? Let's, we talk through it. Then they usually put it on their phone and they go away and take a look. FAQ sheet to take away and review. They're already in existence and online and available. You can modify as is. The psychology space is, during COVID, it was really hard to get psychologists. Now it seems to be a shift towards really supporting engagement with clients, because I think possibly less referrals are coming through. So people have the space to be able to communicate between sessions. So things like, how are you going? What do you reckon? I gave you this stuff. We talked about this app. Are you in it? Are you keen? That's the between support, and that arguably requires effort and time to be able to do that, depending on caseload. Engagement support, again, brief email. How are you going with X once you've signed up? What do you think? Any problems? Some of them a lot of the ones that I use have built-in assessments. So I'll get an email to go, oh, a little bit elevated on the anxiety. There's a whole discussion point online around the challenges of what you do with that, because obviously it's about managing risk as a clinician. But it gives you an opportunity to reach out and go, hey, what's happening? I just noticed this. You know, do you need to come back in? Do we just need a quick phone? Do we or a Zoom chat? Where you at? What's going off? So we've really moved away from that model of the psychologist sees the person once a week, once a fortnight, whatever it is, and then they disappear into the ether and then they drop back in your office again. There's so many opportunities with the digital tools to be able to continue that engagement and build and support that therapeutic alliance between sessions. Again, the knowledge and tools review. It's like, okay, so I've noticed you've been using this, or you're telling me you're using Contain Your Brain. What do you think? Is it working? So that CBT skill that we talked about, how's that working for you? When's it not working? So it's really nice just to get some supporting evidence for how that works. There's one other bit I want to mention. I don't know that it sits here, but I'm going to flag it anyway, just because it's sort of it's the other part of my interest in terms of using digital tools. I use a lot of wearable data with people now, so biofeedback. And for the tablets that we're incorporating into our sort of our residential rehab, there's an option there for people, say, who have an Apple Watch, to be able to integrate or to be able to log on and be able to see their data. So what happens then is we go, okay, we've got Insight Timer in there. Maybe you could do a mindfulness activity, and let's see what happens to your biofeedback, basically. What does your data show? Or they do something that sits within Apple and then use that to reflect on any changes in the data. Because if they're with us for a month, then the algorithm gives us a bit of time to be able to look at that. That's then a tool for them when they go home to be able to keep an eye on. Not everybody has that, but it's something that I think also is really helpful. It's like we're missing a whole piece of the picture by just focusing on, you know, the thoughts, the conversations. There's a whole nervous system data generation that we don't have access to, but that gives us so much information. If anybody wants to chat about that further and what that project could look like, I'm more than happy to talk. And that is it. Wasn't too bad. Thank you. Thank you.
I actually like the sound of the wearable and the biofeedback, because I think about working with clients in between sessions and they come back to you and you've given them a sheet and you ask them, please, could you fill this out every day, maybe before you go to bed, just to mark what's been happening for you throughout the day. If you've got a watch on that's a wearable that's taking note of your heart rate, you can't remember necessarily what's been going on for the week, or it alerts you to kind of go, oh, hang on a second, something is going on here. So it's in real time. And there's a record of it to jog your memory when you come back and see me, or you get an alert with an email or a little note on you. I love that.
Yeah.
See, it's exciting. So we all should be digital champions, shouldn't we?
Yes.
That's it. Beautiful. Thank you, Ruth. Oh, actually, Ruth, don't go away. I'll pull up Peter and Heidi as well. And I'll get you to stand. If I could get you guys just to stand off the previous presenters. A little bit off to the side. Talking stick. There you go. We have multiple.
Thank you.
Oh, Deb's got. Okay, so any questions from the audience for Peter, Heidi, or Ruth? Thank you very much, Deb. The look I get as she walks past me. That's it.
Yeah, thanks very much to all of you. I guess my query is, and I don't know if it's, I guess, my own bias, but the kind of speaking about the digital literacy stuff and the digital champion stuff, majority of patients who access our service, community public mental health service, have a primary psychotic illness, not depression or anxiety. Pretty profound, I'd say, in most cases. impact on executive functioning, volition, things like that. Is there any evidence about the use of these specifically for patients with primary psychotic illnesses? The uptake of it, I guess there's been some instances where we've tried it and it's been useful with kind of a blended approach, support workers, NDIS support workers assisting in using it. But yeah, I'd be interested to know if there's any information on that. It seems to me, yeah, a lot of this that you see is about depression and anxiety. And I guess Peter would just be interested to know in terms of, is there any co-response in terms of like I'm presuming more specifically those crises kind of requiring intensive police presence with mental health services, what that would look like in that instance, how that would work in kind of remote locations.
Do you want me to start, Ruth, and then hand over? So, yeah, there's actually some research going on at Swinburne University who are looking at using these tools, digital tools, with people with more severe and complex mental health issues, and it's definitely part of blended care. So, yeah, they definitely do it. But, yeah, they are doing quite a bit of stuff on that, so worthwhile looking at that. And then I'm happy to talk to Ruth, hand over to Ruth in terms of talking about actually using in terms of practice elements.
Yeah, so my response to that is probably, well, it is. There's some guides or checklists out there, and Heidi might remember what they're called. I can't remember who produced it, but I think ensuring appropriateness of resources for clients is the very foundation of what we do. And there's a number of checklists that encourage you to go through specific things that will pick up what you're talking about and either preclude or not the appropriateness of a tool for someone. I would be incredibly cautious. There's a lot of people that I work with quite as a standard, but yeah, I think it needs some really careful consideration.
And I think that's why they do generally say these tools are best for the lower intensity mental health conditions. So having said that, I know there's some work going on at Origin as well, and they're doing some VR stuff as well, and they're finding that can actually help in certain circumstances under the care of a clinician as well, helping people manage some of their symptoms too.
And I can answer that. The co-response, because of the size of Queensland, co-responder models are highly effective, but you'd be lucky to get 3 or 4 people on a shift. Like if we've got an ex-co-responder here from Logan, who could probably talk about that a bit more. But the model we have in the model of service with our clinicians in our comm centres, on that night that we were, and that went right through the night, they provided advice right through. We've got access to a psychiatrist as well. We were ringing them about other jobs that were happening on the Gold Coast, in North Brisbane. And so they're providing a statewide service. And I said, we've used them in ULO all over the state. And so that service is fantastic, and really designed because of the size of Queensland, but it's certainly being looked at now from other jurisdictions around the effectiveness of it, because it's so adaptable to, and the model's been built in a certain way that it really does provide the best services for the people on the ground, and it's adaptable enough to go into different areas. So even where there's some intersections of disabilities, it can link in, or it can certainly start to link those services.
Any other questions from the room? No. Questions online, Amanda? No. I think there's, I had one question for Ruth and I kind of missed it. It was about the gamification used as follow-up. I kind of didn't quite understand. So whether or not you'd be able to give me a re-explain.
I can. So I guess an example of that, I don't know, people here who have kids and are probably so familiar with Snapchat, they have streaks. So they will send each other a picture every day. And then somebody sends it back and it builds streaks and they get to whatever number, and then there's like, it's not good if they lose the streak.
Yeah, that just showed what a dinosaur I am there.
Yeah, so it's like that. So there's a lot of some of the ones. So Try Dry, which is for alcohol abstinence, Reframe has them. There's a lot of apps that give you your visual count. You mark each day, or you go in each week and go, I haven't drank for these days. And you get a visual of it, and it tells you how many days you've got unbroken, how much you've saved, those kind of things. But there's the imagery is really powerful in supporting people to not want to lose the streaks. Not dissimilar to how we see kids on Snapchat. It's like they don't want to lose it. And, you know, there's a whole range of discussions and research around why that may be.
It's like a behavioural reinforcement.
Absolutely. Yeah, it maintains motivation.
Yeah.
Really. So it's as simple as that, really. I feel like I should have some data, but I don't.
There's some research going on overseas. I know in the UK they've got partnerships with researchers and private game developers where they're actually building mental health things into games so that people are learning that way. So that's an interesting sort of thing that I think could happen more often going down the track as well.
Yeah, I think so.
Yeah, and I also have the image of virtual reality being used in situations where we can't put people back into those situations if it's trauma, or we can't put people into risky situations to test behaviours. Yeah, very interesting. We've got some.
Hi, yeah, a Peter question. You mentioned PAIPs, the police and ambulance intervention plans. Any really good tips and tricks for making them really fantastic plans for emergency services to use? I guess sometimes there's a bit of a disconnect between maybe clinicians knowing what they should be writing and what's important, and what you guys find is really important.
That's a good question. So one of the things we look when we go, I call it the first sweep. I'm looking for anniversary events. I'm looking for similarities in behaviour from what's happening now to what's happened in the past. And if there's a correlation, that's awesome, because when we can then start to look at the strategies that worked previously. If there's a disconnect, that's just as good feedback for me to go, something very different is occurring here. And that's why I'll then pivot the first responders to go, I really need you to focus on what matters to this person today. Something's happened, or we're going to have a really deep dig. This is a consistent behaviour over a period of time. And so really looking at we work on behaviour. And that's what a lot of the work we do with the clinicians is distilling the information from a clinical base to a behavioural. What are we looking for? What are we looking at? So we're looking at that behavioural response. So even just a pattern of behaviours at times is really useful for us, because we're trying to line those up to get, we think that can be used here, or this is very different to what we're currently facing.
And we have one question from online.
Yes. Is there a particular group, age, location, gender, that have better results with digital mental health apps or services?
That's a good question. Interestingly enough, I'll start that people often think that young people are going to be, more likely to use digital tools. But when older people are actually enrolled into the MindSpot course, they've actually got an older person's course for people over 60, they're much more likely to complete it. So they find out of any of the other groups, and that partly because they've got more time as well too. But there's nothing that's really shown up necessarily in terms of males or females or age. I think definitely people who tend to have more of our education and tend to have English as their first language tend to be more stronger users of tools, and that's because these tools are more easier for them to use. So hopefully over time there will be more tools to address some of those other issues, especially, different languages, different skill levels as well, as we talked about in terms of digital literacy, but also just mental health literacy as well.
Right, so no other questions. So thank you very much for our presenters. And, too hasty.
Thank you. Sorry, just at the end. So my name's Sarah. I'm from Darling Downs Mental Health Service. One of the questions I had was, is there a current program around looking at things like cognitive remediation therapy or SCIT being used through the VR or through other sort of digital resources? It's something we find a lot is hard to get people to those groups because of their remoteness. So just wondering if there's any platforms or classrooms at the moment that are being worked on for that.
I don't know of any.
I don't know if there are either. Yeah, I think that's one of those gaps, unfortunately. Yeah.
That sounds like a project for someone called Sarah.
Yeah, that would be a very good project.
We've heard it all here first today. No pressure. Yeah. Yep. So no other questions. Fabulous.